Hi, everyone. Firstly, I'd really like to thank BCNA, Vicky and KP for asking me to travel up to this beautiful part of the world. And all right then. Especially if you saw Melbourne the last few days, it's been pretty average. So I'm very appreciative to be asked to speak to you guys today. This is your session. So if you don't agree with something I say, or you want further clarification, or you want to ask a question, please just whack your hand up or call out. Don't wait till the end. If you're like me, you forget by the end what you wanted to say. So let's just have it as a bit of a, if there are points that are raised, I think it's really good if people are prepared to contribute. Of course, it's not for everyone, but let's see how we go. And what I really wanted to focus on was current and emerging treatments to support patients living well with metastatic breast cancer. So I suppose the first thing to do is define what we're talking about. So we know that breast cancer that's localised to the breast or the lymph glands under the arm or in the neck is really considered early stage breast cancer and typically treated with a combination of surgery and other modalities. But if the breast cancer has worked out how to spread beyond that area, it's called advanced breast cancer, stage 4 breast cancer, metastatic breast cancer. And the X-ray you can see down the bottom, normally the lung field should be completely clear, and unfortunately this patient has got some patchy white areas representing the breast cancer having spread to that area. So the most common way we find a patient diagnosed with metastatic disease is that some years ago they presented with an early stage breast cancer. They underwent the usual treatments with surgery, maybe hormone blockers, chemo, radiation. And down the track, they present with new symptoms and they have scans done which unfortunately reveal changes in keeping with stage 4 breast cancer. A smaller proportion of patients present with what's called de novo metastatic disease. This is where a patient either presents with the lump in the breast and they do scans to make sure it hasn't gone anywhere else and they find there is unfortunately spread to other parts of the body, or alternatively the patient presents with a sore back, never having had a breast lump, and when they do scans they identify that the breast cancer has spread to other parts of the body and that indeed there is a lump in the breast. And the importance of knowing about that is that often it responds extremely well to treatments. Different cancers like to spread to different parts of the body. So for oncologists who work with patients who've got lung cancer or melanoma, they know the parts of the body that they need to keep an eye on to make sure the cancer hasn't spread there. And for breast cancer, it particularly likes, for reasons that we don't really understand, lungs, liver, bone and brains. Sorry, your one brain. And it can basically get there two ways. One is that it travels, the most common way is in the bloodstream. So originally when the patient had the breast cancer in the lump, for reasons we don't really understand, a rogue cell jumped into the bloodstream, lodged in a bone somewhere, went to sleep for 5 years, and 5 years later reactivated and started growing and forming stage 4 disease. It can also spread through the lymphatic system, so we know the first place breast cancer goes is the lymph nodes under the arm, but then it can spread to other lymph nodes around the body. Clearly, a diagnosis of a stage 4 illness is devastating for the woman or man diagnosed with this condition. However, there have been huge gains in our treatment options, meaning we have patients these days who have incredibly long survival with their disease. Not every patient diagnosed, but many. And we hunt continues for the holy grail of curing stage 4 breast cancer. I know it's always very disheartening when a patient comes in and we start talking about stage 4 disease and they say, how many stages are there? And it's devastating to hear that they have got the most advanced form. There's a particular subtype of breast cancer called HER2-positive disease, where we've now all, as oncologists, got a few patients who've had this illness for 10 or 20 years with no spread of the disease after the initial treatment. And we do believe potentially they might be cured from stage 4 disease, which will be a huge development. One of the most important things when dealing with an incurable illness is getting the balance right of the doctor-patient relationship, in my opinion, because the patient has a very loud voice in terms of, excuse me, what treatments they might consider. Many patients who had chemotherapy when they had early stage breast cancer and the cancer comes back, you know, it's not an uncommon thing for someone to say, Michelle, I'm never having chemo again. I'll consider other treatments, but I wouldn't do that again. And we need to know how the patient feels about treatment. We need to educate them about how things might have been different now to then. But we really want to make sure the patient's voice is heard in those discussions. And sometimes I'll have patients who say, I hear you saying this would be the best and this would be the second best, but I keep my hair with this one and I can keep working with this one. So I'm going to, for the moment, try that one. And I always, you know, I like the patients telling me how they feel things are going. It's always tricky if patients say nothing because you don't want them to leave and then be thinking, oh, I should have told her that, you know, this is what I'd like to consider. It's critically important that when a patient's diagnosed with stage 4 disease that we biopsy the cancer, if at all possible. Sometimes if a patient's just got cancer in the bones, it's not really possible to do a biopsy. It's technically really hard, or if there's spots in a part of the body that's not safe to biopsy. But in all other circumstances, we think that's really important. Sometimes a CT will look like it's stage 4 breast cancer, and actually when they do the biopsy, thankfully it's something else. But also, very importantly, sometimes when breast cancer comes back, it's different to how it was originally. So sometimes a cancer that was hormone-driven originally is no longer hormone-driven. And the importance of that is if I just put a patient on a treatment that worked for their original cancer, I might putting them on a treatment that's actually not very useful. So we would always try and get biopsies, and indeed, we're now really keen, if the patient is agreeable and has got something easy to biopsy, to do that multiple times during their cancer journey because, again, along the way, the cancer can change again. It's a tricky beast, unfortunately. And the reason we're doing the biopsy is to try and work out what subtype of breast cancer we're talking about. The vast majority of breast cancer is hormone-driven or estrogen receptor positive. But some of them will also be what's called HER2 positive. So there's that little overlap between the two bubbles there. And the bottom group, the basaloid or triple negative breast cancer, is unfortunately the most potentially aggressive subtype of breast cancer. The reason I want to know that information before I start treatment is I want to give the right treatment, and I also want to be able to discuss honestly with the patient prognosis if that's something they want to discuss at that time. And there are different prognoses depending on the subtype of breast cancer. So this cartoon is just sort of explaining these different subtypes and how it might impact on treatment. Luminal breast cancer is a term oncologists tend to use to describe a hormone-driven breast cancer. But luminal can be either luminal A, if it's very hormone sensitive, or luminal B, if it's a bit less hormone-driven. HER2, as we're going to discuss, is a particular subtype where we've got really great emerging treatments. And finally, the triple negative breast cancer that, again, there's a lot of research looking at new treatments for these patients. So when we're seeing a patient newly diagnosed with stage 4 disease or at a point where one treatment has stopped working and we're looking at what we should do next, we love the model of what are called multidisciplinary meetings. Do you guys know, does that term mean something to you? No? So that's good. I can explain something. So a multidisciplinary meeting is essentially where clinicians who are involved in the patient's care get together and look at what's happening and make recommendations about what would be the best treatment for that patient at that time. Now, for patients with early stage breast cancer, they're routinely done when someone's first diagnosed. And it's really only been in the last few years that's been a recognition, well, what about patients with metastatic disease? Why aren't we having similar meetings to discuss the goals of their treatment and what would be good treatments for that patient at that time? I work at Monash Health in Melbourne, and we're very lucky. We've got a nurse practitioner who's driven the development of our metastatic breast cancer meeting. We hold it every week. We discuss all new patients or anyone who's at a crossroads where we need to make decisions about their treatment. And we have radiologists, radiation oncologists, we have medical oncologists, nurses, psychologists, palliative care doctors, it's absolutely fantastic because then we sit all together, we review everything and we make recommendations. And for the patients, there's huge peace of mind from knowing that it's not necessarily just one doctor planning one particular step. It's really that community approach. So let's talk about some treatments of the common subtypes of metastatic breast cancer. And starting with the most common, the hormone-positive breast cancer. So many patients diagnosed with metastatic disease that's hormone-positive think they should be on chemotherapy straight away. They think chemo's the strongest medicine. Why is my oncologist putting me on hormone blockers when I had chemo before and now they're not even talking about chemotherapy? And there's been a real shift in the way we manage metastatic hormone-positive breast cancer because our hormone treatments have got so good. So hormone blockers are absolutely our preferred option for a woman or man diagnosed with stage 4 breast cancer. And a couple of reasons for that. They work better than chemotherapy. Patients have better quality of life. They're often able to work if that's something they wanted to do. And in addition, I think it enables the patient to, maintain the best quality of life they can. And they often work for years, which, chemotherapy, as we know, can work for a period of time, but eventually the cancer will develop resistance to the treatments, whereas the hormone blockers can sometimes work for very long periods of time. So for women who've been through menopause, we typically would use an aromatase inhibitor. We've got 2 that can be used in combination with the other drugs I'll discuss in a minute, letrozole or anastrozole, or fulvestrant. And sorry, down the bottom it should say premenopausal. So premenopausal women also get these same drugs, but they need to have something to make them postmenopausal because these drugs only work if you're postmenopausal. So they can either have an injection in their tummy once a month into their abdominal wall that tricks their body, or some of them would consider with time to have their ovaries removed so they don't have to keep thinking about having that injection every month. Sorry if you don't like needles, but that's the injection. So I just want to say it is a horse needle. It is a horse needle. I've got a couple of patients, don't ask me how, but they do it themselves. It's not medically recommended. I say to them, no, I definitely would not. But they say, look, Michelle, I've been doing it for such a long time now. But it is a reasonably big needle. For men diagnosed with metastatic breast cancer, they need to also have this injection to suppress testosterone production, and they would have similar treatments to women with metastatic breast cancer. We would try to avoid them using testosterone. We know that our hormone blockers are associated with side effects. Some of them are listed here. And really, from a quality of life perspective, can have a really negative impact. But we do have drugs to help with at least some of these side effects. And one of the most important things, I think, is for the patient to feel that they can talk to their oncologist about these issues. Because, if you are having 50 hot flushes a day and you're not dealing with that, you're going to get sleep deprived. And, it really wears you down. But some of the other side effects we see are weight gain, impact on libido, vaginal dryness, which can really have a very negative impact on someone's sexual health. When I talk about vaginal dryness, patients will often say, oh, we're not sexually active. And it's not just about sex, the vaginal dryness. If it's itchy and bleeding and sore down there, that's a really bad quality of life. And so I think oncologists are not very good at discussing some of these things. We're like, you're on a good treatment and it's working really well, so let's just leave it there. But that's not really how medicine works. And if we're wanting a patient to be on these treatments for years, we need to find treatments that are sustainable. Other hormone blockers, we know tamoxifen can have some side effects. And the other side effects we often see with these aromatase inhibitors are stiff joints. I can usually pick a patient in the waiting room. When I call their name, they all get out of the chair quite similar. Once they get moving, they're absolutely fine, but that initiation of movement is just a little bit slow. And they can get carpal tunnel, and we were hearing before about trigger fingers and all, they really can cause a lot of musculoskeletal symptoms. So this treatment is quite good as first-line treatment, but when we use the hormones alone, unfortunately the cancer, being a clever little beast, works out how to develop resistance. And so then we were all very excited in the last 5 to 10 years when this new group of drugs called the CDK4/6 inhibitors were found, and these have revolutionised first-line treatment for hormone-positive breast cancer. So I'm not going to make you have a biology lesson, but essentially they have an impact on cell division and growth and essentially help the cancer, stop the cancer developing that resistance. We've got 3 drugs in the family, and because we like to sound very smart, we give drugs very long names like ribociclib, palbociclib, abemaciclib. These are all very active drugs and have really, when given with the hormone blockers, have really made a very effective treatment as our first treatment for metastatic disease. They do have side effects because, of course, all medications have side effects, and the first 2, palbociclib and ribociclib, tend to have similar side effects. They can cause your white cells to be low, so everyone has to have regular blood tests, and they can also cause rash and nausea. They're given a funny schedule. You take them for 21 days on, and then you have 7 days off every month. And during that week off, those white cells wake up again, and then your blood counts are good to go again. The other tablet, abemaciclib, you take all the time, so it's given in quite a different way, and its main side effect is diarrhoea, which for some people can be really debilitating. I think last time we gave this talk, a patient had got some app that could tell them every single toilet, public toilet along, I can't remember which highway we were talking about, but, you know. See, it can be very, and the problem is there's an urgency with this, with the diarrhoea. It's, so it does need to be monitored.
I'm going to jump in. We've got Lisa, who is a strong advocate for palbo here. That was pivotal to Lisa, and you pop your name up for Michelle. Lisa went to supporting government. I used to go to Hong Kong to get my palbociclib once a month.
Yeah.
Or he'd let me come back with the fulvestrant injection.
Yeah.
Every 2 months. And I ended up not being able to go to Hong Kong anymore. So with Greg Hunt, BCNA, and Bob Catter, we got it on the good year, 2000.
Well, bravo, because, I
worked for me for 5 years.
Yeah, no, indeed. And, we're very lucky in Australia, thanks to you guys, that now our patients, patients often say when they look at the box and it says the drug costs $4,000 a box and they're getting it, as a standard script. It's a huge achievement. So thank you. Okay, I'm going to move to HER2-positive breast cancer, unless anyone had any questions they wanted to ask.
One question. If you take an estradiol
Yep.
and that fails,
Yep.
is it fulvestrant the same thing?
No.
It's a lot stronger.
It works completely different way. Yeah, so one of them is stopping production of estrogen, the anastrozole, whereas the fulvestrant is having an impact on the estrogen receptor. So they have completely different mechanisms of action. So, yep. Okay, HER2-positive disease. So this is certainly the subtype where we've seen massive drug development in the last 20 to 30 years. We've got very good standard treatments that luckily in Australia we're able to access. Typically it is given with chemotherapy, so these drugs are pertuzumab and trastuzumab, continuing the big name theme, and they're given with some chemotherapy, which again can cause side effects. Predominantly the one we worry about the most is this peripheral neuropathy, which can be an incredibly debilitating side effect of our treatments, and needs a lot of monitoring and it's a real art of managing it enough that the patient's getting a good dose but not getting the peripheral neuropathy. And usually you do the chemo for some months and then continue on with these antibodies. So this is just a little cartoon. The image on the left is showing a normal breast cell that's got a few of these HER gates on the surface, and the middle graphic is what we call a HER2 amplified cell. So it's got way too many gates. And you can see the little electric charge going into the centre of the cell, which is the nucleus. So all those messages are telling that cell to grow and divide. And then the image on the right is this drug Herceptin or trastuzumab, binding to that little gate and stopping that message getting to the nucleus, so stopping the cancer cell growing. Very clever. And in oncology these days, we have these very complicated algorithms about how to manage, I'm not going to go through this just so you know, Just trying to show how complex it's become, because we've got these beautiful algorithms that, big international bodies in the US and Europe have developed that enable us to give our patients in Australia. We don't have access to every drug that's listed here, but we are pretty lucky. And the other area that's really taken off in HER2-positive disease is something called antibody-drug conjugates. And I'm just going to move to the next slide because I want to explain it to you. So an antibody-drug conjugate is essentially where you take an antibody, which is the long bit in the middle, and in this case it's going to be Herceptin, and what you cleverly do, I don't personally do it, but I'm happy to take credit, is you glue chemotherapy to the antibody. And what that means is that the chemotherapy gets delivered only to the cells that have the protein that the antibody will bind to. How clever is that? With the whole concept being the rest of your body hopefully doesn't get the chemotherapy, but the cancer cells do. So these are definitely the way forward, and I reckon in 10 years that's all we'll be talking about. We've got a few drugs in this area already in the HER2-positive space, Kadcyla or TDM1, and the new very exciting one is this Enhertu, which we believe will very soon have PBS listing. And this is just an example of how they work. So the blue thing is the HER2 protein. Remember I said the cancer's looking for that protein, and the TDM1 or Kadcyla with its funny structure glues there and then chops off the little chemotherapy molecules that you can see inside the cancer cell and kill the cell. And if that wasn't smart enough, now the next class they're called the second class of these antibody-drug conjugates. Not only do they follow that pathway, but the little cell down the bottom, it doesn't have that protein on its surface, but now can you see the little yellow molecules? It's released them into the tissues around the cell up the top, and it's going to kill the bottom cell even though it doesn't have the HER2 receptor. And that's something we see where not every cell in the cancer sometimes is the same. And so sometimes our treatments don't work as well because we're only getting one bit of the cancer, we're not getting all of it. And so this is really going to revolutionise our treatments. Moving to triple-negative breast cancer. As we've discussed, this can be the most aggressive subtype of breast cancer, and until recently, really the only treatment that we had available was chemotherapy. However, immunotherapy has now available in Australia for women who are PD-L1 positive. So again, if you have a protein on your cancer cell, currently there's an access scheme that women and men are able to access the immunotherapy, and hopefully again soon this will be on the PBS. And it doesn't work, unfortunately, for every patient, but some patients are having very long responses to this treatment. And immunotherapy is a completely different type of treatment to anything we've ever done before in cancer. So we always have wondered why, if a cancer cell is weird looking and doesn't look like your normal healthy cells, why doesn't your body attack the cancer? Why doesn't your immune system get rid of it? And what cancer cells are clever at doing is looking sort of close enough to normal cells that they escape that sort of immune response. But what these drugs do is they make your immune system supercharged so that your immune system now sees these cancer cells, and when you give it with chemotherapy, it's a really active treatment in trying to kill them. For some cancers like lung cancer and melanoma, it has just completely changed the experience of patients, and patients are being cured from illnesses that in the past they would have died quite quickly from. In breast cancer, to date, most of the evidence is in the triple-negative patients, but there's emerging evidence that it may also have a role in other subtypes of breast cancer, so it's really a space to watch. And when we first found these drugs, we're like, thank God we can stop giving so much chemotherapy with all the side effects that we generate with our drugs. But then we started meeting the side effects of immunotherapy, and while they're uncommon, they can be really very serious. And indeed, the oncology wards these days are often filled with patients, that small group of patients who've had bad side effects from the immunotherapy. Because when we supercharge the immune system, as well as attacking the cancer, sometimes it attacks the patient's own organs. So it can affect the thyroid gland, heart, lung, kidneys, pretty much any part of the body you can think of, it can attack. And it's been a steep learning curve for oncologists to know how to manage these side effects. And indeed, emergency departments are still finding their feet. They'll often say, she's on chemo and she's come in with, the side effects. So we're all still learning how to manage these side effects, and there's a really big element of teaching our patients what sort of side effects to look out for, because rarely they can be life-threatening. And that's where we start looking at having the village of doctors managing a patient. So some of our patients now who are on immunotherapy, they're seeing an endocrinologist because their thyroid's not working well. They've had some inflammation of their lungs, so they're seeing a lung doctor. They've had bad diarrhea because they've had colitis, so they're seeing, a gastroenterologist. There can be a whole lot of doctors involved in their care as a consequence of this very good treatment. In triple-negative disease, remember that antibody-drug conjugate we talked about before with the backbone and we glue the chemo on? Now we've got a drug for triple-negative disease using that same model. So they found a protein on triple-negative breast cancer, and they've produced an antibody to it, they've glued the chemo to it, and again, BCNA and consumers played a really major role in getting this drug approved on the PBS. And this is a pharmaceutical company, make it look very attractive, doesn't it, really? So you can see the backbone with the funny chemotherapy molecules all attached to it, and it's a really active drug, and some patients are getting huge benefit from it. And the last little new treatment area I just wanted to talk about was what's called HER2 low. Remember we talked about the HER2 treatments just being if you were in that small percentage of patients that had too many of those little proteins on your cancer. What they're now discovering is that patients with hormone-positive disease and triple-negative disease, some of them can have a little bit of HER2 activity, and the breast cancer treatments that are coming through for HER2-positive disease do seem to have activity. And this is going to open up these treatments to a much wider group of patients, which will have cost implications for the government. But, at the end of the day, we're here to advocate for the best treatments for our patients. So I think, it will move forward and be an active treatment over the next, couple of years. There was a big clinical trial called the Destiny 12 trial that looked at this new drug called trastuzumab deruxtecan, or TDXD, which really showed this was a very active drug in that situation. And it's just going to give us another treatment option up our sleeve. The thing is, it's going to be a big patient population, right? And so I think...
Is there not enough numbers, like HER2 low?
HER2 low, it's been surprising how little data there is, because in the past, pathologists just reported positive or negative, and now they're kind of working out, actually there's this group in the middle, and so I think there's a lot of work. The company involved, I think, really working hard to try and work out how many people we're talking about so that they can go to the government with good figures. The data is clear, right? This is an effective treatment, and there will be many, many patients who benefit from it.
It's going up on the November payback. Okay. And we're negotiating just price point at the moment for an access program, because that's been looking at an access program. So we're working out. We're working at the moment, but they're putting it up on the November meeting. Okay. Yeah, which is a good sign.
Yeah, but if you see that, they always love expressions from consumers, expressions of interest from when any drug's going up. But this will be a game changer.
What's the difference between HER2 positive or negative?
Yeah, so...
Which is the more common?
Well, the more common is HER2, what we used to call negative, but that term's going to go, because now it's going to be either low, amplified, ultra low, or negative. It's going to be much more complicated. But it's really just about, does the cancer cell have lots of that protein on its surface? And now we're turning to our pathologists to try and gather as much information about, in the past they used to just say not amplified. And now we're like, nah, we need to know more information. How much activity was there? Because could this patient be a candidate for these new exciting treatments?
New options.
Radiation has a really important role to play in patients diagnosed with metastatic disease. It's a very good treatment if someone's got a painful metastasis or spread, particularly in their bones. It can help if we're worried that they're going to have what's called spinal cord compression, where the cord gets compressed, or other blood vessels, or if the brain is involved with brain metastases. It's a very effective treatment. But what we're really focusing on these days is what's called stereotactic radiation, where rather than treating just a lot of radiation to a big area, you give really high-dose radiation to a small area, and maybe you can actually even destroy that tumour deposit with these high doses of radiation. So this is used commonly if someone's got 1 or 2 or even a small number of brain lesions, rather than in the past we used to treat the whole brain, which resulted in a lot of side effects, really quite significant fatigue and tiredness. So now if we can just zap the little areas, it's much, much better, much, much better. There are clinical trials going on all around the world looking at trying to use this technique. So maybe if someone's cancer just progresses in 1 or 2 places, rather than changing all their treatment, you zap those areas and you keep going with the same treatment, because then you might get longer on a treatment before you have to swap to the next one. And that's a trial I've been involved with the AVATAR study that's just presented overseas in San Francisco, which was very exciting, and it's demonstrated that using this sort of technique can improve how long someone stays on a treatment with a really good quality of life, which is very exciting. And these are some complex images of them planning that stereotactic radiation, where you can see the yellow is where they're trying to get all their different radiation beams all coming in different angles to really target a high dose in that small area. No.
So he worked out of PA, but he does work out of Reading Slopes as well in Brisbane.
Yep.
He actually did sub-millimetre radiation. And I went to him, my brain.
Yeah. It's amazing. And that's definitely the way forward. We think, treating just tiny little areas before they become problematic is much better than, giving big treatments across big areas.
Is tomotherapy the same? Tomotherapy radiation?
No. Is that a sub?
So I had tomotherapy radiation in Hong Kong and my bones in my back. And
Maybe that's another term. It's not.
What did you call it?
Stereotactic. No worries. I think Vicky already mentioned we're really focusing on the world of personalised oncology, rather than just saying, well, this treatment worked for 100 other patients diagnosed with metastatic disease. Now we want to know what is driving this cancer's growth, because that's what we want to target. The usual approach of starting a new treatment, you cross your fingers and toes, you do a scan in 3 months and see if it's worked. If we're better at identifying what are the genes driving the growth, we'll be better at providing the best treatment. So this is the whole new area of personalised oncology. There are tests that have been around for a while that essentially where you send part of the cancer to a laboratory and they produce these reports that tell you what were the drivers of the growth, what new treatments might be possible, what clinical trials are around that you might be eligible for. Now, this is one of the original tests, unbelievably expensive, I think about $7,000, beyond the reach of the vast majority of patients. But the good news is that lots of entrepreneurial labs are now developing these tests in Australia, very targeted to particular cancers, so for example, breast cancer. Most of these tests do need some of the cancer specimen to do this analysis, but more and more of these tests are coming through and they can just use your blood. So there'll be some cancer DNA in your bloodstream and they can do these clever tests just on a blood specimen. And so this is going to be the way forward very, very soon. And just to finish up, I just wanted to talk about, the importance of that really holistic approach to dealing with patients living with metastatic disease. We want to be making sure that it's not just about your oncologist, it's about your metastatic breast cancer nurse, it's about your radiation oncologist. Many patients still keep a relationship with their breast surgeon if they've got to know them and they're part of their treating team. But psychologists and exercise physiologists and many, many members of the allied health team, are critical, absolutely critical, because I'm sure, as you're about to hear, one of the most important things is going to be making sure we keep our patients as fit and healthy so that they tolerate the treatment the best. And that's just not everybody that's part of that village, but some. We've already talked about clinical trials. They're absolutely the way forward for us to identify our new treatments, and many times they allow our patients to get access to drugs they otherwise wouldn't be able to get. And it's important to talk to your treating team if you're interested in clinical trials. Some patients are not. I know we've spoken in the other group about the challenges for patients who live rurally getting access to clinical trials. I think COVID did mean they revamped a lot of clinical trials. There's a lot more telehealth involved, and that certainly is a really good model for patients, who might have to otherwise travel 3 to 4 hours to get to somewhere to be part of a trial. And genetic testing. I think genetic testing should just about be standard of care for all patients with metastatic disease. Yes. Oh, yes. There are cost implications for the government, but actually, so if you fit the criteria, you get a free test. But the tests are getting cheaper and cheaper, and I think we don't talk enough to patients and their families about whether that's something they'd like to fund, because it might present new treatment options such as olaparib or PARP inhibitors, but it also is going to have implications for the risks of children and other family members. And finally, I think we need to make sure we're really dealing with the complications of our treatment and managing them as best we can. Hair loss, mouth ulcers, impacts on mental health, the neuropathy, fatigue. I think we really need to make sure that our patients who are living a long time now with metastatic disease are really getting the help they need, and often it's going to be about the multidisciplinary team. It's going to be about their exercise program. They might be having acupuncture to help manage some of their symptoms, that really holistic approach. Bone metastases are one of the feared complications of metastatic disease, can really impact quality of life, and we know patients can break bones, they can have pressure on their spinal cord that can make them paraplegic, and also can result in one of the salts in the blood, your calcium, being very high. And so we have very good drugs which are known as the bisphosphonates, such as zoledronic acid, or denosumab or Xgeva, that are given regularly to patients to minimise these risks. So it is a devastating diagnosis to be diagnosed with metastatic breast cancer, but I think there's great hope in the new treatments that are coming through, and the relationship between the patient and their treating team is absolutely critical. We do need multidisciplinary teams managing our patients. It's not just about seeing your oncologist and getting good scans. It's about having that true holistic approach for both the patients and their family. And we continue to hunt for everyone being cured of metastatic disease. Thanks.
Thanks so much, Michelle. We've definitely got time for questions, so I'm going to roam around with this mic. Michelle, I've got a question. Being in Canberra last week, there was a real sense that treatments have just come so far in the last, 5 years, and how fast things are moving. There was definitely appetite from the government, and Minister Hunt was in the room when Rare Cancers released their report last week, talking about the need for us to continue to move faster. And certainly BCNA is involved in a number of key activities to look at reviewing the process for drugs being listed, because we know that the delay is 455 days from when a drug is able to be listed to when it actually gets accessible into the hands of a patient at limited cost. So just getting your sense of, how far have we come? And seeing your passion and excitement, there is hope, and just getting that sense from you. I might get you to stand here and I'll roam around.
So it's a common situation where we'll go to one of the international conferences in America or Europe, and we'll hear about these amazing new drugs coming through and extraordinary trial results, with patients having very different outcomes if they get access. And then we come back here and we talk to patients about it, but we have to say, oh, but really sorry, it's quite a few years away from being, something we can access here in Australia. And I think we do have to get better at the process, because it's too slow. It's too slow. And, we've seen with the CDK4/6 inhibitors, I'm told the story, I don't know if it is true or not, that, originally trastuzumab or Herceptin got on the PBS because Raylene Boyle sat next to John Howard at some lunch, right?
Correct.
And so all the other things that had taken place, it just took that one-to-one personal contact for him to really, get his head around it all. And that's where I do think BCNA and consumers have a really powerful voice, because I don't know, sometimes you feel like as a doctor when you're putting forward these cases, they must, the government think you're just wanting more patients or more work or whatever it is. But, I think that the patient voice is loud, and I think we need to start streamlining this process, because it's farcical, Some of the immunotherapy discussions we've been having on and on and on, and we all put in applications, to the PBAC. We try to, as oncologists, we try to help the pharmaceutical companies as much as possible to present the information in a way the government are going to see it as being clinically meaningful. But I think I'm glad I'm not in charge of the budget, because I think it would be a really hard decision. Like, some of these drugs are super expensive. I think, that negotiation, getting the drug company to maybe get their price down a bit more so that it's, maybe. Yeah. I'm such an optimist. But, there has to be something, because I think, these drugs are going, and the thing about some of these new drugs is patients might be on them for years. In olden days, when a drug was active in metastatic disease, often patients were only on it for 2 or 3 months before, unfortunately, the cancer progressed. Now we're seeing patients, 3, 5, many years on these treatments. So I think we've just got to keep campaigning, and also I think, meeting as groups together to try and work out how to brainstorm better approaches.
Yeah, fantastic.
But I'd be interested in other people's opinions.
Yeah, comments, questions?
Just with that pertuzumab too, just like all drugs, I suppose, but I didn't realise that you can actually have a reaction to a drug years later. It's not something that happens within 24 hours or 48 hours. You can actually be 3 or 4 years down the track and then react to the drug. Because I've actually reacted to pertuzumab 3.5 years in. And I didn't know that. I was sort of really dumbfounded about that, because I just was like, oh, okay. I rocked up, didn't feel well. I flew back from treatment, didn't feel great, put it down to a cold, got back on the plane again, flew back for treatment 3 weeks later, came back home, was really not well, and we couldn't work out what it was. And then I got back to Brisbane. I got back on a plane and went back to Brisbane, and they said, Dr. Grimes said to me, oh, Mel, you've had a reaction to pertuzumab. I went, but I've been on it for like 3 years. And he said, it's not unusual. He said, it's fairly, it does happen. He said it's one of those things that, it can happen 3 or 4 years down the track.
So it's working well.
Fine. Fine, but the reaction was really, really bad. Yeah, I had to learn to walk again. Like, it was very bad. But I'm just saying, like, if you don't feel great one time and you kind of can't pinpoint it, and you're going, it's just the flu, I'm just a bit sore, I've been gardening, just check.
There's a fine line between intuition and paranoia, isn't there?
Yeah, just check. Because the second time,
paranoia, but your intuition is screaming at you there's something wrong.
And I think what a lot of us do is we don't think it could just be a backache. We automatically go to cancer.
Oh, no, I didn't do that. I was like...
Yeah. No, I don't mean you, but...
You can either swing either
it can
way.
be
You can
mixed-
either just go,
mixed
nothing,
up.
or
Yeah.
you seriously, every time
Yeah.
I sneeze, oh my God, I've got
Yeah.
cancer in my nose.
My GP told me he was feeling neglected because I never went to him anymore. I just went back to oncology.
He was neglected. That's the first.
I think it's absolutely true. I think whenever we're thinking about causes of new symptoms, we do need to evaluate whether the drugs are causing side effects.
I didn't jump to that. I would never have jumped to that. Like, it was only that David Grimes said to me, straight up, he came in and he walked in and he went, looked at your chart, I can tell you now that I think you're reacting to the pertuzumab. What?
So did they stop instantly? Did they
Yeah, I
have to
had
stop?
to. Well, you'll laugh, because I said to my oncologist, David was filling in for Victoria Belinsky, who's my oncologist in Brisbane, and I said, so are we going to try it again? And she said, did you not have enough fun reacting to it, Melanie? And I said,
Oh, no, I didn't really enjoy it. She said, it's not going to get any better. Oh, okay.
Can people have those reactions way down the track when they've been
Yeah.
on these drugs? Yeah, right.
Particularly the pertuzumab. I've had a few patients who either get this terrible itch,
Oh, no,
can't get rid of the itch, or
I got an itch. I did get an itch, and I guess I'd had that from the start. So
Right.
I was that person that for 12 years went to the bed ice packs like every week.
Right. But yeah, sometimes we do, and I was going to say particularly the immunotherapy, you can sometimes see quite late effects from that, a year, even after people have stopped the treatment, that autoimmune process can be an issue. So clinicians do need to, think about it when they see patients with weird symptoms,
Because they go through that list, the nurses go through that whole list. Have you had this? Have you had that? I was like, I had a bit of the flu,
Yeah.
I didn't worry about it too much. Had the next round, went home and...
Michelle, just a quick question or comment. Do you think if it was a little blue figure all there instead of all the pink dresses, we would be on some of these new trials? Do you think they'd be going through the PBS quicker?
Nah, I reckon they'd be slower. Because you know why? Because there is not, I don't have many male patients, so I probably shouldn't, but there is not the same voice, right? Women are powerful, I think. I know what you're saying in terms of, I think prostate cancer treatments, for example, don't seem to be, whisking straight on to the PBS. I think if there wasn't the advocacy, maybe you could see that sort of sexism, at some level. But I think with the loud voice women have, heaven help them not do the right thing.
Michelle, how do we as patients, your patients, help you to get what we need? If that makes sense.
Yeah.
Because you have the contacts, we don't. All we do is go to our doctors and say, okay, but how do we push you to go that step further for us?
I think you help guide us how far you want me to go, right? Because some patients will literally say, you know what, I hear I've got metastatic disease, it's small volume, I want to be living as normal a life as possible. So, we'll keep the treatment as simple as possible. But if someone says, right, I am investing everything in getting, disease control in the next 6 months, where would the clinical trials be that offer me the greatest opportunity? Is there something I can spend money on? Sometimes doctors hate talking about money. It is not our gig, right? Yeah. And so we often just don't do it. And then sometimes you'll say, oh, there is this drug, but it's going to cost you a lot of money. Patients go, yeah, I'll pay that. So they're awkward conversations, because the worst thing would be if a patient walked out thinking they thought I needed them to find the money.
I mean, to go higher.
From an advocacy perspective.
Yes, sorry, that's the word. Because where I'm coming from is, it's crickets. We have no mental health help, nothing. So how do I get my oncologist on board to use our voices, because there are a lot of us, to push him to push harder for his hierarchy and advocate? Does that make sense?
It does, but you'll be disappointed to know that we don't have much of a voice. I work in a big public hospital that has the largest number of breast cancer patients in Victoria, and we have very poor psychologist support. We virtually have nothing. We're always telling patients, go to your GP, see if they've got someone in the community, but we should be referring them to people who specialise in people diagnosed with cancer, not someone who might never have seen anyone. So I think, it's that next level up, well above treating doctors, that we need to kind of be engaging with, and that's where I think, BCNA are being your voice. They're pushing hard on those topics, that it's pretty hard for either an individual doctor or an individual patient to have that voice.
It is a hard one, and I think it's come up quite a lot around equity of access. And, we've certainly heard here around travel,
Yeah.
the challenges around travel to get to a clinical trial and then the travel's not reimbursed. And so, it is the role. And what's been your experience?
Oh, well, being in the paediatric sector, we're mollycoddled, so it's pretty lucky. But as soon as my daughter turned 18, we had to start paying for a lot more things because she wasn't a child anymore.
I do think the bond between a patient and their treating team can be really powerful.
And if you've got a good team, you've got to stick with it. I mean, at the end of the day, what cost is your health? Without your health, what do you have?
Yeah.
Nothing.
And we've got to trust instantly, which is hard.
You've got to either like them all. I mean, I had chemo one day and rocked up to see this doctor, and he was 3 hours late running. Do you know how bad I had a 2 hour? I was in Cairns. I had a 2 hour and a half drive home to my farm. And he's keeping me waiting for. Are you joking, mate? Like, do you know how I'm feeling? Like, poor you. Like, I just went, see, I'm out. Like, and then when I found out he hadn't even started me on the job, I was like, yeah, no, I'm out.
Yeah, we did talk next door as well about second opinions, because I think, that's one of those things.
The key to that is, I look at it now that you're on my payroll. So if you're not doing what I expect you to do, I fire you, you're gone. I just move on. And I have done that across the 15 years. That to me is the best way to look at it. If you don't like someone who is treating you, do not stay with them. Have enough backbone to say, I don't like it, I'm out. And I've done that. I've done it with an oncologist that was just absolutely a shit show. And I went, yeah, you know what? And my husband's sitting there going, I could see the steam coming out of your ears. And I was like, no, I'm going to be polite. I just held it together, nice and polite. And as soon as I walked out and they said, oh, so Melanie, when would you like your next appointment? I went, I'm never coming back. See you later. And I walked out.
And a lot of the time we don't have choice for second.
Yeah.
Second
You have to do it.
opinions.
I mean, it's like Cairns or town. You have to make that. Sometimes you just got to suck it up and do it.
And I think, Jess, like we talk about the access to metastatic breast care nurses, I know that McGrath is working incredibly hard to, I know that their vision is for 250 nurses by 2025. And certainly Metastatic has grown as far as service delivery and the role, I think you spoke about the role of navigation and cancer councils and, the not-for-profit cancer organisations when, the Australian Cancer Plan's about to come out from Cancer Australia, and there's a lot of talk around the roles that we play as far as navigation for people, where to go, where are some services that people can find, because it's not always easy to just be able to travel or make the decision to move. Access for everyone is very different. Jess, I just wanted to get, just before we wrap up, just to get a sense from your perspective, particularly for people with metastatic disease.
And I guess the big thing is that we all recognise that we need to do better in this space. And I guess that's why McGrath have come with the metastatic breast care nurses, so that we can do better in this space. I've worked up here for about 20 years now and have worked in oncology services throughout sort of Cairns and the Cape and Torres as well around oncology services. And definitely around 15 years ago, it was quite devastating what was happening here. We didn't have oncologists on site, we didn't have radiation. There was lots of different things that we haven't done, and definitely we have improved those services, but we still have got a long way to go. And I think by having BCNA come up and being a voice for you guys as well, myself coming on board and making sure that we put metastatic breast cancer in front of everyone's face, things like multidisciplinary team meetings and things like that, which are going to benefit patients, but also helps us as clinicians to do the right thing as well. And talking and feeding back to us is really important as well, because we can't improve our services if we don't know what's wrong with it. So we do really appreciate knowing when something's not working for someone. And I guess too, part of my role is really helping. We know that travel is a huge issue. We know that access to care in these areas is definitely lacking, just from the remoteness and just the lack of services that we have as a community, just being a small community. we need to be creative, and hopefully my role as we move down this path, the more connections we make through days like this, we start to find those little pockets of specialised people that we can start linking our patients in with, and hopefully giving people better access to care.
Thanks so much, Jess. I think you touched on, and we're going to wrap it up, but I just wanted to say that you touched on some of the side effects associated with endocrine therapy. Tonya Mazzini is about to do a presentation straight after lunch around sexual wellbeing and sexual health. And for us at BCNA, Breast Cancer Awareness Month is living well your way. And I think this afternoon we've got Jodie and others to talk about exercise, and all of these things are really important when we talk about, we heard from Michelle, the side effects and symptoms of long-term treatment. And so please stay on for this afternoon to listen to these key speeches, because I think that they will be fantastic and really insightful. And certainly Tonya's got a wicked sense of humour, and she did the same presentation this morning to health professionals online and again last night. It's fabulous. So I hope you'll get something out of it. Please stay connected with us at BCNA. We don't like just coming up here and dropping in for an information forum and leaving. You provide us the insights to understand the unmet needs in the community. We will take it back. I will talk to the policy and advocacy team. But please stay in touch with me. I'm certainly on LinkedIn, and I know the team can be contacted through our helpline and through the email addresses. But please reach out, because it's really important we stay connected and support our partners with McGrath. And we work very closely with McGrath. So, where we see there's need, our role is to advocate, and their role is to provide the services on the ground. So thank you to Michelle White, and fingers crossed with this. There's some of these drugs on the PBS in the next couple of months, but watch this space, because there is a lot happening. So thanks so much, everybody.